Okay, moving on. Let's talk a little bit now about assessing the fifth vital sign, which we all know now is going to be pain. And so while you've been in nursing school, it's been part of a routine to conduct that pain assessment frequently during your shift. That's not always been true because we've not always been really into doing that. But this semester we are going to be doing that more so because you will be given both IV pain medications along with your oral medications, so it's going to be very important for you to reassess that pain. And so this is kind of why pain is going to be called the fifth vital sign, so that we remember to assess that at all times. It's hoped that by adding this as your fifth vital sign that the data collection becomes more, becomes better. And so remember, when you're doing your pain, you want to be assessing both your subjective and your objective data. So as we go through this, I'm going to bring in, and I forgot to bring this in, I collected it yesterday, but ministry is now doing something different with their pain, and so anybody going to ministry, this will be something they'll have to do, is that you actually have to fill out a form now to hand to the chargers to make sure that you've actually done your pain assessments and reassessments. So when you give an IV meds, it needs to be reassessed within 30 minutes, PO meds within the hour. So another thing, better data collection, and it's a way to ensure that patient's pain is being actually taken care of. Okay, so let's first look at the objective observations that you're going to see in somebody that has acute pain. Okay, so tachycardia, increased heart rate, blood pressure changes. Initially, you're going to see an increase in their blood pressure, and then it's going to decrease. Diaphoretic, restless, splinting painful body parts. I think you all know that. I remember one time when I was in labor, and I remember I was having contractions. They were so bad, and there was nobody in the room, and my epidural wasn't working, and I just remember all I could do was just hold myself because it hurt so bad until that went by. Same thing with anybody that has, say, a broken rib. It is so painful that what do you actually see them doing but splinting that painful area. They may grimace with pain, and that might be what you see in somebody, is just that grimace where that facial expression tells you everything about the pain that they're in. They may be moaning or crying. I don't know how many times I've seen people moaning and crying. And you know, that too, it's an objective sign, but it's taken subjectively by the person that sees it. You know how you always tell your kids there should be tears associated when you're crying? So do you think that with adults, if they're in pain, there should be tears associated with it also? It doesn't have to be, no. So crying is one thing, and typically you do, but men can be very stoic when it comes to pain, remember, and they will show very little observations that you'll be able to see, but some of them that you will be able to see would be the crying. I've seen grown men, kidney stones are about the one thing that'll bring a grown man to his knees in pain, crying. So, tachypnea, of course, increased respiratory rate is something else that you're going to see in somebody who has that pain. So let's look then again at how would we self-report pain. You want to ask questions to help clients describe their pain. And so healthcare agencies use a variety of these techniques to assess if someone's in pain. So your textbooks provide some very nice examples of this. And if anybody wonders if they should buy their textbook, I would strongly recommend it. Basically, what you're going to want to assess when you're doing a pain assessment on the patient is the location. And always start with where does it hurt? Tell me about the pain. Describe the pain for me. Ask them to how much are they willing to tolerate for pain. And then determine what is the patient's goal in regards to pain. So location. Tell me where your pain's at. Well, it's right here. Okay. What is the quality of that pain? Is it dull, sharp, stabbing, picking, prickling, that type of pain sensation? How long have you had that? When did it start? How long has it been going on? And are there patterns with it? Sometimes gallbladders, you'll see cyclic pain that happens with them. You know, where when they have those attacks, it'll be the same type of pain that goes on with that. What is the severity? How severe is this? Tell me on a scale of 0 to 10 how bad that is. 0 being none, 10 being the worst pain you've ever had. And that's pretty subjective too in there, but whatever they're telling you, remember, we can go back to the pain scales that we looked at to look at it. Is it moderate, severe pain. And then, of course, treating that pain will go along with that. What are aggravating factors? What do you do that aggravates that? What makes this hurt worse than what it already does? And what are the effects on daily life and function? Are you able to do anything when you're in this type of pain? And then, like I said, there's some questionnaires in your book that you can see, but these are all questions that these should be ringing bells back to you, because we've done this in clinical already. We've asked these questions already, but it might have been in a roundabout way with that. And many of us have to chart it this way also. So, one of the things that we can do for patients when it comes to additional methods that we are going to use to assess their pain is, especially those patients that have chronic pain, is to do some sort of pain diary with that. And so they can keep a history of when that pain is, what they're doing. It'll start showing a pattern over time with that type of pain that's there. And so the better the pain is going to be understood by the provider, the better the nurse or the provider can individualize the plan of care for that person. So important to have them keep that sort of a diary. Now, here we talk about these numbers and word modifiers I just made reference to. When you're using a 10-point scale to assess someone's pain, from 0 being none, 10 the worst pain you've ever had, you can see the relationship between the numbers and descriptors here. So 0, no pain, of course. 1 to 3 is mild pain. 4 to 6, moderate pain. And 7 to 10 is severe pain. And as you learn, when we start looking at the WHO pain scale, you're going to learn as to what we can treat this patient with according to those numbers there and the descriptors that are given. So let's talk about some factors that influence the response to pain, or how that person is going to behave when they're in pain. And so you wonder how they're going to react when they're in pain. Well, some people may be fearful, they may be apprehensive, they may be anxious, whereas other people may be more tolerant and more optimistic in regards to treating their pain. Some people that are in, and we talked about this, that are in pain, they're going to weep. I've seen people scream. I've seen them moan. I've seen people beg for relief of their pain. Just give me something that's going to take this pain away. It's so bad. So that will happen also. And others are just going to lie there quietly and not say a word to you about their pain. So you may have to ask them. They may close their eyes. They may grit their teeth. You know, somebody's sitting there, you know they're in pain just by the reactions of their face, that those objective observations. But we need to ask them then. They may clench their fists, because that takes their mind off of that. I think in my discussion board, I'm not to change the subject, but in my discussion board, we were talking about, online, we were talking about the gate control theory. And so one of the discussion board questions was about that and how that works. Well, anybody that listened to the Packer game pregame yesterday would find out that Aaron Rodgers used acupuncture all last week prior to this game. So one of the questions I posed then to the person that answered this question was, well, tell me how acupuncture works to alleviate pain using the gate control theory. Do you remember how?
Bigger nerve fiber as opposed to the small. And if you stimulate that one instead, then that pathway, the larger fiber will be the one that transports the signal as opposed and block that smaller pathway.
Yeah, it's going to, but remember that when you're giving somebody acupuncture, that's what? Right. Well, but it's going to distract that pain. Exactly. So their pain is not going to be, and it's going to be kind of those endogenous opioids that are, they make you feel good. So using acupuncture takes away from the pain that the person's feeling, but it doesn't last forever. No, because what happens when you take ice off a sprained ankle? It starts to hurt again, exactly. So you see what's going to happen here. Not to change the subject, but I thought it was interesting that we had talked about that in class. Look at their prior experience. How did they tolerate pain in the past? That's something that you can ask them. And they may have learned techniques in the past that might help them to control their pain. On the other hand, previous experiences with pain may cause a person to feel more threatened by the painful experience because of the amount of pain that they were in. Think about the child who's had their immunizations, okay? They have no idea what's going to happen to them, correct? And so when they're given those injections, they scream. So what do you think is going to happen the next time they go in for that same sort of thing? Anxiety level is going to go sky high. Exactly what's going to happen. They're going to scream again. So that can be a very traumatic experience, going to have your immunizations done. You can think about, let's see, we also need to look at their cultural behaviors and values. Think about cultures. There are cultures that are more stoic than other cultures. We know that. The Hmong men, even the women, tend to be very stoic. The Amish tend to be very stoic and don't want much for pain medicines. So we also have to think about that and think about their values and their perceptions that may influence their pain perceptions there. Along with that are your social expectations. We've all heard that big boys don't cry. Well, big boys do cry, especially if it hurts a lot. And so if you're taught that at a younger age, that big boys don't cry, what's going to happen? You're not going to cry. But if you're truly in pain, you're going to cry. So that's another thing you can think about with that. Remember that responses can be learned. So when you look at the parental attitudes towards pain, how the parents perceive pain can be a learned behavior by the child about pain and responding to pain. Because remember, that child is going to take their cues from who? Their parents, exactly. So that can be a learned behavior with them. Think about in the settings of Super Bowl, I'm going to use Richard Sherman even though I despise that guy. I went after him yesterday because I knew he was hurt. You could see, remember, anybody watch the Packer game, the way he was holding that? I was totally convinced it was a wrist injury. I was really convinced that. My husband said, though, it was an elbow injury this morning. But if you think about that, in a normal setting, in a preseason game, would he have played when he got hurt? Absolutely not. Why risk his career, right? But in the NFC Championship game, in a chance to go to the Super Bowl, what's going to happen? He's going to play hurt, and he did. And did you notice that every time he lined up and they showed him, he had grimaces on his face and that arm was clutched to him? But did you notice who never got the ball then? We never threw the ball to that guy. I'd have thrown it. I'll tell you what, I should have been the coach for that game because I'd have changed a few things in a hurry there. So anyway, but do you see how the setting can influence how somebody responds to pain? When you think about support people, they can impact the patient in various ways. If there's a lack of support, the person may ignore their pain because they don't have to work to pay their rent. So why would I bother? You know, they're just staying home. They don't have to do anything. You could almost put that to a kid in school. They hurt themselves. They don't have to worry about anything. They don't have to. They can just stay home, do whatever they want. But you and I, we have a job. And so what does that mean? If we don't go to work, who's going to pay the bills? I don't know about you, but last I checked, my parents weren't paying my bills. So you can see that that's another thing that you can look at. Their emotional state is also going to influence their pain. And we talked a little bit about this with the gate control theory. Fear, anxiety, and depression are all going to impact how somebody tolerates pain. If you think about pain may be blocked during an activity of intense concentration. A war. If you're a soldier fighting in a war and you've been shot, but you're still able to maneuver around, are you still going to fight? Because you know if I don't fight, what's going to happen to me? I may not come out of that. So as you can see, or it may be increased by anxiety or fear. Fear might be a patient having surgery for the first time. Remember that a person who's depressed has a lower tolerance to pain than does somebody that is not depressed. So serotonin, remember, is involved in the modulation of pain in the central nervous system. So in clinically depressed patients, that serotonin is going to be decreased, leading to an increase in pain sensation. And so stress and anxiety, we know, are going to intensify the painful experience. And so that's something you have to keep in mind. Preparation for pain. If the patient does not know what to expect the likelihood of pain and the outcome of treatment is going to be more negative than it is going to be positive in that painful experience. So we all have been through pediatrics. We all know what child life does. If we prepare those kids for that painful experience, they do a lot better than if we don't prepare them for that painful experience. Although some kids just don't do well in general. And then, of course, if you think about health professionals' response to pain, something else to consider, if the nurse is slow to respond to a patient who's in pain, the patient's more likely to watch the clock and request pain medicine sooner. So they're trying to prevent themselves from inadequate care. And then remember that a lack of sleep also makes a person less tolerant of pain. So let's take a look then on some special populations. We're going to go through these 5: elderly, pediatrics, language barriers, cognitively impaired, and those that are unable to speak. So let's start out first with the elderly population. Now, when you can read for yourself some of the geriatric considerations here related to pain listed on the slide. But because the elderly are more likely to have chronic illnesses, they're more likely to have pain. So remember, to assume pain is present in cognitively impaired patients with conditions commonly associated with pain. So you may want to consider for them an analgesic trial. What is going to work, what isn't going to work. We want to start slow, start low, and go slow when drug dosing, especially to those elderly folks there. Remember, their metabolism they have slower metabolism and greater fat to muscle ratio. So small doses of analgesics may relieve pain and last longer than that. One thing to remember is not to give your patients meperidine or Demerol, especially if they're elderly. They can have this, but some considerations to remember with this. But we should avoid it in the older adults. And we'll talk about that here in a little bit. You want to be aware of adverse effects of Tylenol. Tylenol is toxic to the liver, exactly. And NSAIDs can cause what? NSAIDs. Kidneys, exactly. So they can cause nephrotoxicity. So very important if somebody's a chronic ibuprofen user that we're going to check their kidney function there. The elderly are more likely to be undertreated for pain. And undertreatment of cancer pain is due to inappropriate beliefs about pain sensitivity. So tolerance and ability to take opioids. So remember that typically we undertreat them, so we need to think about ways that we can better treat those folks. Pain is not a normal part of aging either, so we need to keep that in mind. Now, when we think about pediatric considerations, children feel pain, including infants. The pain assessment needs to be adapted based on the developmental level of the child. And so a couple of scales that we can use, remember that facial expression scale with the smiles on it is one. The other one that we can use is the FLAC scale. That's also in your textbook, that face, legs, arms, consolability, and crying. We use that one in pediatrics. Let's see, we can use the NIPS, which is the neonatal infant pain scale. We'll look at that in a second here. But do know that we want to use an age-appropriate scale for these kids. I've tried many of these pain scales. I've tried the FACES scale on a 4-year-old, 4 or 6-year-old. I'm not totally convinced that it really works because she was happy all the time. But in fact, when Mom says, but remember when you had that tummy pain and you were crying, did you still feel like that? And she said, no, I felt like this with the tears coming down. But she still went back to the happy face every single time. So when I triage pediatric patients, I tend to try them out and see, but I've never been really sold on which one works the best for kids. But when we look at the neonatal infant pain scale, you can find this in your London book here. Oh, I have that on. It's actually page 1056 to 1057 in your London book, the 4th edition book. So just make that change in there. Oh, why do I have it here? Oh, well. I might be using the wrong PowerPoint, but it's the same one. we'll see. Anyway, because the nurse cannot collect subjective data now on the infant, objective observations are what's going to help determine the severity of the infant's pain. So they're going to look at facial expression, cry, breathing pattern, arm movement, leg movement, and the state of arousal. Another thing we're going to look at here is talking to the parents about past behaviors with pain. Okay? And so when we talk to the parents, ask the parent how the child describes pain. For many of us, we don't say pain. You might say boo-boo, you might say ouchie, or some other word that will help describe that. And then you want to know, will the child actually tell you if they're in pain? So that's something that you're going to want to ask the parents about that. But very important to find out how the child describes pain and how they describe pain at home. This is your best way to assess pain, is by talking to those parents with that. Ask them, how do you know when they're in pain? And I can relate that back to when we're taking care of, in pediatrics, the cystic fibrosis kids. The kids that they can't tell you that they're in pain. And I remember specifically asking one mom of a CP kid who had leg surgery. And I says to her, because he was nonverbal, and I says, how do you know he's in pain? And she says he moans and groans more. And that's how we gauged his pain then, was by the moaning and groaning that he did. So there are different ways that you can assess that in those kids. Now, the parent can also provide insight to the child's current pain. Listen to the parent. If you were the parent, you'd want somebody to listen to you about your child's pain. So asking the parent how, what they would like to do can help build rapport between the nurse and the family there. The parent likely knows interventions that are helpful if the child is in pain. So what would you like me to do for your child? So, you know, some of the questions I might ask the parents is, did you give them Tylenol or ibuprofen before you brought them in and they have a fever of 103.3? What do you think they say? No. You know why? A, they don't have any. B, they wanted to see how high the temperature could get before they got there. Okay? And they wanted the physician to know that this child really had a fever, because anybody who has children and you've given them Tylenol or ibuprofen before you've left for that 102 temperature and you've gotten to the, it's gone. It's gone, and they kind of look at you like you're half crazy, you know. Oh, absolutely. I've been there, done that myself, so I'm with you on that one. So you see, by asking them, what is it that I can do for you to help alleviate their pain, they may answer that. Tylenol, ibuprofen, ice. Some people, they say, well, I don't know. That's why I brought them here. You need to help me fix them, and so we do that. But ask the parents about it, because they know more about their kids than what we do. So you can see that they're going to be an important person for you. I use them very well. Now, if English is a second language for people, the patient may have problems relating to pain. And so this kind of shows some conversion to the rating scale. You want to use simple word descriptors. When you say pain, they all, regardless of whether or not they can speak English, can tell you yes or no. And so yes, then typically you need to wait for an interpreter, because we know they have pain. We can treat that pain. We're not going to know how bad it is, but we need to get an interpreter, whether it's via the telephone or whether it's face-to-face, but we'll need to get somebody in there to help us with that. But you can see, you know, pain, severe, hurt is moderate, ache is mild, is kind of some, for those that have language barriers there. And what about the cognitively impaired and the nonverbal folks? Well, assessment techniques need to be varied for those folks, and especially if a person is nonverbal, such as somebody who's got a breathing tube in or intubated. You want to do a simple pain scale. But like I said before, for the CP kid, you're going to want to use, you know, behavioral cues is something that would work with them. But first, make sure the patient's not able to use a pain rating scale. Don't assume ever that someone can't use one, because that would be wrong on your part. Sometimes a 5-point scale is going to be a whole lot easier for people to understand versus a 10-point scale. When you think about the person that's intubated, and say your hands are tied down to the side of the bed and you've got this breathing tube sticking out and you can't talk, you can't do anything except nod your head, and that's where you'll ask, are you having pain? Yes. Is your pain Oh, say they had belly. Is it in your belly? Yes. So then we'll treat your pain according to that. You can have them write also. Many people can write, but you're going to have to take a chance of them not pulling that tube out. But the one thing about having a breathing tube in is, I don't know about you, but people will hand you, typically we use black Sharpies or we'll use pencils, because you know how it is about writing upside down like this? Your ink is going to run out. But we want them to write one word to describe something for us. Typically, they want to write you a sentence. And I don't know if you've ever done this to anybody, but that sentence tends to look, I mean, it can look anything like this here. I mean, that's that's a drama, I know. But you can't read it. You can't read it. And little old ladies typically try to write very neat, but take a clipboard and lay in bed tonight and try writing. Have somebody hold it there, and you try writing with this, okay? With a pencil. It's going to be very hard to write. And you know what? Most of those people can't see what they're writing, so they're kind of like this. You know, they're writing pain is, and it goes all over the place. They have no clue on it. But try to make it simple for those folks so that we can get that pain treated right away. Secondly, anticipate pain and proactively treat it. Look for behaviors that indicate pain. And the pain head scale may be useful in clients with dementia. But when you look for those clues, they're moaning, they're groaning, maybe they're fidgety in bed, maybe they're restless. There are things that we can, especially if they're nonverbal and cognitively impaired, that's where you can find out from the family or the caretakers how they act when they're in pain. Now, when we look at the pain head scale, this is what we're talking about here. And these aspects will overlap a little bit to the neonatal, the NIPS one that we also use here. But you can see it looks at breathing, negative vocalization, facial expression, body language, and consolability. So you can see we're going to rate that on that. So it's on a 10-point scale, and we'll be able to treat their pain accordingly to that. Fourth, we may use proxy pain here. Proxy pain reports can be used for this population, just like they're used in children. So a spouse or an adult can provide valuable information to you, but remember that a proxy is making an educated assumption. So again, you know, my mom has severe dementia, but how do you know that she's in pain? Well, she mumbles more, she babbles more, or she doesn't say a word. So you can see there are different things that we're going to use to assess that pain for these folks. Now, another thing to consider is when substance abuse is involved here. If a patient has a history of substance abuse, it can be more challenging to treat their pain. And so both the patient and the healthcare provider are going to have concerns regarding effectively treating the pain while avoiding addiction to that analgesic. Okay? So we know they already have substance abuse, but is it going to become more than that? So the history of addiction needs to be discussed with the patient. So careful assessment is going to be required for this. Patients deserve, remember, adequate pain control. And inadequate pain control is going to increase that drug-seeking behavior. So discuss with them relapse prevention with that. You know, and when we think about substance abuse, we're not just talking about alcohol. We can be talking about pills also here, or the diversion of narcotics along with that. So it's not always easy to assess pain. There are barriers to a pain assessment, and a patient may not always report their pain. And here are some reasons why people don't report their pain. They don't want to bother others. Think about that little old lady that comes in with pain. She doesn't really want to bother you. She's just happy to be there, but she doesn't really want to bother anybody, and she's just going to go to sleep for a little while. They have fear of an injection. How many have had an injection? I am? They're not very pleasant, are they? Even sub-Q is not. I had sub-Q heparin, and that burns. So people don't really like having injections. People often think that they're going to become addicted to the pain medication. We need to clear that confusion up, because while you're on a short course of medications, do you really think you're going to be addicted to it in that short of time? No, I can go back to my mother. She had hip surgery, and one of the things that they give patients after hip surgery is OxyContin, oxycodone. OxyContin, your 12-hour long-acting, oxycodone, short-acting. Well, then when she got weaned off of that, he strongly suggested for a while that she take oxycodone every night before bed, because people who have hip surgery tend to have something with the nerves, restless legs. And so she started taking that every night, and I said to her, I says, you can't take that every night. I says, you're going to become addicted to this stuff. You're going to realize that you need this. The only way you're going to be able to sleep is if you take that oxycodone before bed. I says, you need to stop taking it. Well, she took it for a while. Eventually the doctor said, well, we're going to have to cut you off of this now, because you've been on it for a couple weeks, and, things should start getting better. Try taking some ibuprofen and Benadryl. So, using it for something other than what the intended use is going to alter the reason that you're taking it. So there you can see, becoming addicted to the drugs is one of the things that can happen there because you need it. Now, they may fear constipation, nausea, or confusion. I don't know about you, but I had a severe migraine last week. And I don't get migraines. But this was so bad that I couldn't even look straight, and it hurt. And so, I decided after taking about a dozen ibuprofen and drinking a couple Mountain Dews, which I never drink, it still didn't work. And I took a couple Excedrin, too. That helped more than anything. And so I thought, I'll take one of these oxycodone. Ooh, geez, I felt fuzzy all over my whole body. And I didn't really like the feeling. I've never been one for pain meds, but I'd had it to about here with the migraine. So that and not being able to breathe was just too much for me, put me over the edge. So, I took one of them, but it was like, I don't know, I felt funny, and then I was nauseated, and, I had them left over from my gallbladder. Well, I wasn't going to throw them away, because you can always use that for something, so. And this was one of them.
I was going to say self-medicating or one over here?
Self-medicating, yeah. So needless to say, so that's where that, that confusion comes in there, so. Expect pain to be inevitable. It's a normal part of recovery. We all know pain is not normal. We don't expect you to be in pain after having any type of surgery. Belief that expressions of pain reveal weakness. Well, I don't know about you, but I'd be more than happy to tell you all my pain because to me it's not a sign of weakness. But remember, cultural things, it does impact that. They do think that that is part of weakness, so that's something else to keep in mind. They don't want more tests. If they tell you you're in pain, what are they going to do? Draw more blood, they can put you through more tests. We all know how that goes. They want to save drugs for when the pain is really, really bad, so they're not going to take their pain right now. They're not going to report that they have pain because they may not have it there. This goes back to the elderly again. Remember, fixed budgets, don't have a lot of money. When it comes to, this year is better than last year because gas is about, what, $3 less a gallon than what it was last year? So these people have a little extra money in their pockets. But think about it, if money is tight, what's going to be given? What are they going to have to give up? Well, they have to give up their pain medications or the heat in the house. Okay? So they may cut that heat way back and save those pain meds for when it's really, really bad because they don't have the money to afford those. They think nothing can be done for their pain, so that's why they don't report that pain. And suffering leads to spiritual enlightenment. So part of what our job is going to be is to correct those misconceptions here. When a patient believes that pain is inevitable or that they don't wish to bother the nurse, the patient can experience unrelieved pain. And so it's going to be important for the nurse to correct all of those misconceptions. Sometimes the nurse is going to have to consult with the patient's spiritual leader or their cultural leader to help address some of those misconceptions. In first semester, you learn that patients have the right to refuse care, and they still do, but that refusal should not be based on misconceptions. So we need to explain the truths about all the pain medications they're taking. Our misconceptions need to be corrected so that they can make an informed decision also. Just because a patient states they deserve the pain does not mean that the patient should not be treated for their pain. So we want to correct those misconceptions. So after assessment is finished, we're going to start putting a treatment plan together for the patient. And this is going to include non-pharmacological and pharmacological management. And so what we're going to look at now is going to be non-pharmacologic management, pharmacologic management, which is going to look at that analgesic ladder. We're going to look at some non-opioids, opioids. We're going to treat side effects. Let's look at some adjuvant analgesics, and let's collaborate with other disciplines for that. So first, let's look at non-pharmacologic strategies. Some of these are going to be cognitive behavioral. And so when writing a care plan, we're not simply going to state implement non-pharmacologic measures because that's pretty broad. Instead, we need to individualize that plan of care. And so we want to identify specific measures that you want implemented when you make that plan of care up. What strategy or strategies you decide on to use should be based on your assessment. And so when you evaluate the effectiveness of the treatment plan that you've chosen, you may want to revise that plan again. So you're going to want to be happy when those interventions work. For example, distraction might be used for your patient. This involves directing a patient's attention away from pain and towards something else. Oh, visualize a happy place that you like being, okay? And somebody might figure sitting on the dock up north fishing, okay, under an umbrella. That might be something that you use for distraction. That may take their mind off that pain. That's going to be one of those endogenous opioids that kind of make you feel good. This is going to go back to the gate control theory again, where it's going to close that gate. Now, you might hear a nurse state, I can't see how the patient's pain is that severe. I've even said that myself, as bad as that sounds. Just a few minutes ago they were laughing and joking with when they had a visitor in the room. To me, it sounds like distraction is working. But yet, in fact, you know what? How many of us have been in pain but still been able to laugh with somebody that came in or joke around with them, but we still may have pain, so we still need to treat it. So it'd be a good idea to incorporate that strategy or distraction into the plan of care and not complain about the patient. So we're still going to treat them with pain medicine, but let's also look at that distraction as something that works. Mental imagery is something that you can also try. Patient visualizes a pleasant feeling, sensation, or event, and they could visualize their favorite vacation spot. They could even visualize the pain leaving their body. But not all patients are open to something like this mental imagery. And remember, these non-pharmacologic methods, not everybody's open to those, so you can try those. Relaxation can decrease a person's stress. And so remember, stress impacts a person's response to pain. So you can see relaxation techniques can overlap with other strategies such as music therapy or positioning. And that environment can be manipulated to be made more relaxing. Think about, is it the green room we have here, the relaxation room? Anybody gone to Brian Sadler's? Yeah, people say it works, some people say it doesn't work, but it's all in what you want. But relaxation is thought to decrease pain by relaxing tense muscles. We can also look at hypnosis. It's a set of techniques that are going to enhance concentration, minimize one's usual distractions, and heighten responsiveness to suggestions to alter the thoughts, the feelings, the behaviors that a person has. But it's particularly useful for patients with chronic pain. Anybody had hypnosis to stop smoking in this class?
I'm going to try it.
Oh, you're going to try it.
I'm going to try it.
Soon?
I'm going to do the weight loss one too.
Okay.
Because I'm worried if I quit smoking, I'm going to gain a lot of weight. It kind of goes. But
Hand in hand?
I have a friend who it did work for, and I have another friend who it didn't work at all for. But they say it's
Oh, it's kind of like Weight Watchers.
your perception of it has.
Either Weight Watchers works or it doesn't work. Either you're willing to change or you're not willing to change. So
I
that's,
picked up in Marshall and it was a group thing and you get relaxed, but it's not. There's some guy supposedly over on Point that does it and guarantees it.
hypnosis.
Yep, in Park Ridge. That's,
If it doesn't work the first time, come back, he'll do it again.
And if it doesn't work
And
that
it's
time,
individual.
Oh.
He'll just keep on trying until,
until he brainwashes you?
that's fine.
Yeah,
with me.
if it works, hey, I don't have to keep
cares?
on paying for it.
Right?
so.
And I'm not, you don't pay for it each time, and then I'm not buying cigarettes. So,
Well, cigarettes is a hard one to quit, so good for you for trying it. Music therapy can be used part of relaxation techniques, but I'm going to caution you that remember that this 78-year-old mom and pops that's in the hospital is probably not going to want to listen to IFC. You probably would like to find a polka station or something like that, which would be more their taste. That's where you incorporate the family and say what kind of music do they like to hear and bring that type of music into the room for them. I've seen many people that have put like IFC on in a patient's room on an 80-some-year-old man having heart surgery, and it's like, really?
Well, here's at the nursing home too, they put on that. It's like your room's patients, the ones sitting out here don't wanna listen to that.
Absolutely. Positioning and immobilization is behavioral more than cognitive. It's used to protect the painful area. So splints, supportive devices should hold joints and in a position of function should be removed regularly to perform that range of motion. I think of the guy I took care of yesterday that landed on his shoulder, dislocated his shoulder. They put it back into place, and now he has to wear that splint to hold it in place so it doesn't pop out again. But that's going to immobilize that until that area's had time to heal. And then while he didn't like the splint, it's going to work. Prayer is also a thing we can talk about. Research has shown the effectiveness of prayer. Many persons use prayer and identify it as being very effective in controlling their pain. St. Joe's did have a prayer team where they would come and pray with you for any reason you wanted. But some people have very strong religious beliefs, and their pastor or any clergy can come in and talk to them, and that may be one of the cognitive behavioral things that you can do non-pharmacologically. So you see where you can't impose your thoughts onto these, right? Now, let's talk a little bit about some more. Let's talk about these. Now, these interventions you see, massage, vibration, acupuncture, and all of these, stimulate the skin and somewhat are going to interrupt that pain pathway. And so massage is a generalized cutaneous stimulation of the body, and the cutaneous stimulation closes the gate. Acupuncture, acupressure, needles are inserted into designated points, and I don't know. I just got issues with people poking me with needles. They can also put manual vibration or electrical stimulation onto these acupuncture needles. In acupressure, finger pressure is applied to specific joints. I think of acupressure when you have a headache and you go to the beauty salon and they wash your hair. Oh my gosh, does that feel wonderful. It's like everything just goes away right then.
That's just the best thing in the world.
I know, and I always say, can I stay longer?
You just keep washing
Yeah.
it, it's still dirty.
Yeah. Wash it again. And I says, what if I wanted to come back and just have my hair washed? And I think she told me it was $3, and I thought, oh man, for $3, if you did a little bit longer, I'd tip you more.
Do they do it in the beauty school here?
Oh, I don't
Because
know.
I would really volunteer.
Yeah.
Oh, I'd volunteer.
A volunteer.
All right, heat and cold also affects the vascular and muscular systems as well as the production of hormones there. Heat stimulates the production of serotonin, which helps the patient feel more secure, serene, and safe. Cold stimulates the production of norepinephrine, and norepinephrine causes a patient to feel powerful, in control. I don't know about that, but okay. Not only they're in control, but they're confident and they're also excited. But the response to heat or cold is very individualized. Often the recommendation to the patient is to use whichever one of the two works best for them. The heat?
Serotonin increase, but you said it makes the patient...
Secure, serene, and safe. Then cold is powerful, in control, confident, and excited. Now, cold is appropriate if bleeding is a concern, remember, because what's it going to do to the blood vessel? Vasoconstrict it, exactly, so it won't be, whereas if you put heat on an area that was bleeding, what's it going to do? Increase the size, and they're going to bleed more, so probably not a good thing then. Let's see, but there's some client teaching that needs to be done when you're using heat and cold, particularly if you're using heat, burning, and if you're using cold, burning also, frostbite there. So we need to make sure that we explain that to them. And you know what, regardless of who the person is that comes in, I still explain that to them over and over and over again. Don't take that bag of ice and just put it on your skin. Instead, put a thin cloth over it, because if you put it on your skin, you're going to get frostbite. You're going to see red in the area, it's going to turn white, and it's going to freeze. The same thing with hot. You're going to burn yourself, blisters going to happen there. So, you want to use a towel or cloth to prevent skin damage, and assessing that skin is going to be very important. So usually it's recommended that it's left on 15 to 20 minutes at a time, then taken off, and done hourly for that. So part of the teaching there. We can also look at Transcutaneous electrical nerve stimulation, or the TENS unit there, that's also based, we talked a little bit about on that gate control theory. Small electrical currents are sent through the skin and underlying tissues, and the amount of current is controlled. So if it's set too high, it's going to be too painful. We actually hooked ourselves up to this to the ICU because we use the TENS unit to monitor sedation in the ICU. So, you know, don't you think it's always best that you feel what they feel? So what we did is you put them on your ulnar artery here. You put them right here. And so they're just regular electrode patches. You put them on there, and then you can dial the current in. Well, I wouldn't do it to myself first, so I did it to somebody else first. I turned the current up. So anyway, it's not nearly, you got to try this stuff once in a while. Oh, I think this one's a little nervous. See, look at her. She's kind of looking at me like, we didn't do it in clinical. I do this at work. Anyway, so we don't use a defib on each other. Yeah, we don't practice with that. No, but it's nice to feel the current that they feel. And it's not nearly as bad as touching an electric fence. Okay? But it's enough where you could feel that current going through your skin. So, you know, but then again, remember that works with the gate control theory there. But, you know, when you think about Klein teaching, if they're going to use these TENS units at home, some of the teaching that needs to go in is they're going to need to know how to use the unit. We never assume anybody knows how to use the unit. Instead, let's just reiterate what they do with it. But they'll also need to be taught how to rotate the sites of the electrodes so that skin irritation doesn't happen there. And so people that have used TENS units have found them to be beneficial with that. So here's a question for you before we go on break. What instructions should the nurse include in discharge teaching plan of a client who has a TENS unit? Yep, and that's what it's going to be, is it's going to be a pins and needles sensation that they're going to get when they get that. Pain relief is sustained while stimulation is stopped? No. The current is adjusted by the physician? No. The electrodes are placed away from the painful site? Kind of defeats the purpose, doesn't it? So as you can see, then that's that. And finally, we'll go through this one too yet. There are other ways that you can treat pain, and often they're used with other methods have not been effective. These are very basic terms that you're going to find here. I don't plan on focusing on these procedures, but you should know they exist, meaning you're not going to be tested on those. So you can put an X through it if you want to, but there's nerve blocks, cordotomies, rhizotomies, neuroectomies, sympathectomies, and spinal cord stimulation. But just know that they all do exist, but we're not going to test you on them. And so, now, before we do that, a patient with a history of dementia suffered a fractured hip. Which non-pharmacologic approach should be added to the care plan? Yeah, consider the patient's ability to focus and conceptualize when using cognitive therapies. Music therapy may be appropriate for a patient with dementia, while the others would likely be unsuccessful or they're going to be impossible to use. You're not going to get somebody who's demented to do guided imagery or hypnosis or progressive relaxation, but that music might be just enough to calm that person down. Okay, with that, let's go ahead and take a break.